Okay, this section is called Preparation for Testing in Pure Tone Audiometry, based on, I believe, Chapter 6 from the Audiology Science to Practice book for this semester. Our objectives here today are to prepare for testing and obtain a case history, perform an otoscopic evaluation, describe audiometric testing environment and how the patient is positioned, discuss why pure tones are used for evaluating hearing and hearing loss, and describe the different types of audiometers and the functions of their basic components. We also want to describe the types of transducers used in audiometry and the advantages for each type. We want to describe air conduction and bone conduction audiometry and how these types of testing are used to determine which part of the auditory system is affected. And we want to describe the steps used to obtain pure tone thresholds, including the up 5, down 10 modified Hewson-Westlake bracketing procedure most commonly used in clinical audiology. We want to determine thresholds from hypothetical examples of threshold searches. We want to discuss variables that can affect thresholds and what can be done to accommodate and or account for that variability. And lastly, we want to describe the methods for testing infants and toddlers using behavioral types of tests. So for preparation for testing, we start with the initial consultation phase. So when a patient suspects a hearing problem, they may want to schedule or discuss with their primary care provider or a hearing instrument specialist or audiologist. So that's their initial target point or entry point into the hearing healthcare system, is either their PCP or their hearing healthcare provider, most commonly a hearing instrument specialist or audiologist. They may also schedule directly with an ear, nose, and throat physician, but usually that's after a specialist referral from a primary care provider. The primary care provider will most often refer to an ENT or an audiologist, probably an ENT most commonly, but secondarily to an audiologist and tertiarily to a hearing instrument specialist. ENT clinics typically have their own in-house audiologists, although they also may employ some hearing instrument specialists or audio techs, but by far audiologists are the most common hearing healthcare professionals that ENTs employ. At the for a daily routine, you want to check your equipment and your supplies. That's the first step for the provider, for the audiologist. So at the beginning of the day, you want to perform your daily listening check on your equipment. You want to check your power cables. You want to check your signal and your hardware. You want to set your audiometer to say 40 dBHL. It doesn't have to be 40 dBHL, but it's a good testing point at 1,000 hertz. Also at 1,000 hertz because it's at the mid-range for human hearing, and it's usually easily identifiable. Then you want to jiggle your cords around to make sure there's no distortion in the cable, no crackling or static in the cable. You want to check your talk back and your talk forward. Talk back being the function where the patient is able to talk and you're able to hear them. Talk forward where you're talking into a microphone and the patient is able to hear you in return. And then you want to check the patient response button. So the patient often will have a response button where they push the button in response to hearing a tone, and you want to make sure that's working normally. The idea is you want to check these things in advance, because if you don't check them in advance, you may have an embarrassing moment where something goes wrong and you're having to check it on the fly. So beyond the signal and hardware, you want to check the acoustic integrity. You want to set the intensity to maximum and listen for a hum through the transducer. You're not presenting the tone at maximum and blasting yourself with it. You're listening to see if there's any additional hum that shouldn't be there through the transducer being the insert earphone, the supraoral headphone, the circumoral headphone, or the sound field speaker, or the bone conduction oscillator. Probably not the bone conduction oscillator so much, but the other air conduction transducers. You want to listen for clicking noise when the attenuators are manipulated. So when you're adjusting the loudness, or the intensity rather, of the audiometer, you want to see if there's any clicking noise that's being produced inadvertently. It's not something that's supposed to be there. You want to ramp up the intensity, gradually raising the intensity in 5 dB steps to a high level to make sure that it's distortion free, to make sure that you don't get distortion when you're turning up the intensity level. You want to do a sweep frequency check. So at that 40 dB HL, which is a comfortable volume level for an average normal hearing individual, you want to sweep through all the frequencies and check to make sure you don't have any distortion or crackling or anything out of the ordinary. You want to check your masking noise to make sure it sounds appropriate. Masking noise, in the clinical sense, is either a broadband noise or a narrowband noise used in the contralateral ear to make sure that the non-test ear isn't helping out the test ear. And then binaural balance. So with the frequency set at 1000 hertz at a low level, around 5 dB HL, doesn't have to be at this exact level, but this is a recommended level. At around 5 dB HL, you want to make sure when you're presenting the tone in both ears at the same time, through both right and left transducers, so supraoral or insert or circumoral headphones, you want to make sure that it sounds equally loud to you. That's operating under the assumption that you have normal hearing. So another important aspect of preparing for pure tone audiometry is infection control. So taking patient safety seriously. It's our responsibility to ensure the safety of our patients, including to make sure that we don't spread disease inadvertently. So that's cleaning off the surface areas in the office, including the headphones. It's using disposable insert earphones. It's cleaning off the bone conduction oscillator to make sure you don't have any contamination through surfaces in general. We're a high-touch profession. Audiology often has items that come into contact with patients, and so precautions should be taken to disinfect the equipment that comes into contact with the patients. So hygiene and barriers, using proper hand hygiene, whether that's alcohol sanitizing solution, whether that's soap and water on your hands, or using gloves to protect yourself from infectious substances. Personal protective equipment. We don't usually use glasses and safety masks on a regular basis, but during COVID-19, for example, that became more commonplace. If you work in a hospital setting and you happen to be working in an area where there's infectious disease, you may have to wear glasses and safety masks. Or if you're working in the operating room, you may have to wear a safety mask, like a surgical mask. That's commonplace if you work in an operating room setting. Before you see the patient, you want to review the chart for the patient. So you want to see the referral source. Why is the patient coming to see you? Who has sent the patient to come see you? Are they being sent to you by a physician? Are they being sent to you? Are they being self-referred? Are they just scheduling the appointment on their own? Is their referral coming from an atypical source, such as, is it related to a hearing conservation program? Maybe they're being referred to you by a hearing conservation company or a workplace employer. Maybe they were being referred to you by public schools. Those are all common referral sources. And what is their primary concern? It's typically going to be hearing issues, tinnitus issues, or balance vertigo issues. Those are going to be the three mainstays of audiology. And then pre-appointment preparation, you want to familiarize yourself with the case history and previous chart notes before the appointment. New patients typically won't have much info for you to review, but that's what you want to do before a patient arrives. You want to take mind of informal and observation and interactions with the patient. So communication and mobility. getting a general sense for that patient's communication ability and general physical restrictions. You want to see how they interact in the waiting room area. How is the patient behaving in the waiting room area? The transition between when they're coming from the waiting room area back to your office setting or your test room setting. You typically begin with small talk, and you get a sense for the patient, their disposition, and what they're there for. They may mention that right off the bat, or you might just have a little bit of small talk to break the ice. Functional assessment: are they struggling to hear you? Are they exaggerating deficits? If they're struggling to hear you, then you know you may need to compensate by using clear speech, raising your vocal effort, enunciating each and every syllable, using more pauses, slowing your rate of speech. Are they exaggerating deficits? Oftentimes, malingerers or those who are exaggerating hearing loss will have overt difficulty that's disproportionate with the hearing loss that you're expecting. They might stare intently at your lips or comment specifically about the difficulties they're having communicating. You'll kind of get a general sense for this through your experience in the clinic when you encounter someone who's exaggerating deficits. So for a case history form, this will tell you a lot of information before you actually see the patient. So this is an example of an adult case history form, and they're going to answer a lot of specific questions about the complaints they have. It's going to let you know, is the problem gradual or is the problem sudden in onset? Is the hearing loss associated with dizziness or tinnitus? What medications are they taking? What is their family history of hearing loss like? Have they had any ear surgeries? Have they had noise exposure? What's the extent of their noise exposure? Have they worn hearing aids? If so, how long have they been wearing hearing aids for? You're also going to find out information about their ear infection history. Do they have complaints of ear pain or oral fullness? Do they have complaints of, do they feel like one ear is better than the other? Do they feel like there was a certain event that precipitated the hearing loss or precipitated the tinnitus? Is there a certain trigger for dizziness for them? Those are all things that are going to be available on an adult case history. And then a pediatric case history is going to be oriented a little bit differently. You're going to have information about their birth history. So were they born via cesarean or was it a vaginal birth? Did they have any medical conditions or syndromes that were diagnosed around birth? Did they have any previous screenings or tests? Did they pass their newborn hearing screening? Did they have an ABR? Did they have a history of ear infections? Did they have tympanostomy tubes placed ever? Have they used hearing aids before? What is their educational history like? Did they have an IEP or a 504 plan? So those are all things that are of note to you when you're evaluating a pediatric patient. So we have already talked about otoscopy. We've had a whole lecture on that. Just briefly, before you move on to testing the patient, after you've already made small talk and interacted with them and taken the case history, you're going to visually inspect the auricle, the ear canal, the eardrum. You're going to look for things like bleeding, malformations, obstructions, fluid behind the eardrum, excessive earwax. A video otoscope may capture pictures and allow for patient visualization. This is usually of more interest to adults than children. It can be helpful for documentation for referring physicians, but the difficulty is how are you going to send that image to them? Email is often an option. Secure email is often an option now. It's not going to fax very well, though. Otoscopy is key for referring out to physicians. If they have an acute otitis media, if they have external otitis externa, the perforation in the eardrum, those are going to be key things to look for when you refer out. If they have excessive cerumen impaction that you can't resolve yourself, you may have to refer out for that. Otoscopy is going to allow you to visualize the eardrum to make sure it's intact, of normal coloration, and in normal position. So here's an image of a person just performing normal otoscopy, viewing the tympanic membrane through the otoscope. Bear in mind that you want to use proper bracing technique. You pull it up and back on an adult ear, and you place your fingers in a position where they can brace against the cheek in case the patient moves their head towards the otoscope so that you don't cause any injury to them. So pure tone audiometry. So audiometry is the measurement of the person's ability to hear. Pure tone audiometry is the measurement of the lowest sound pressure level that a person is just barely able to detect. It's a detection threshold performed at various stimulus frequencies, or what we hear as different pitches. We're looking for threshold. Usually we define threshold as the lowest sound pressure level that a person can detect 50% of the time, but you could also use 66% of the time if you wanted to. It comes from the Latin, audiometry comes from the Latin audire, to hear, and metria, to measure. Stimulus frequencies that we often are going to test are 250 to 8,000 hertz. Pure tone audiometry does not necessarily represent how a person hears in the real world. Think type of stimulus and intensities used. We're measuring pure tones at a variety of presentation levels, at soft presentation levels in particular, but neither is it's not intended to measure how well a person is able to hear in everyday life. It's intended to measure the loss of audibility for that person. Hearing in everyday life involves complex auditory processing, whether that's in the periphery or the central auditory nervous system. It includes important cognitive contributions. We do have tests that are able to measure more complex auditory processing, but pure tone audiometry is not one of those tests. So pure tone audiometry is almost always part of the test battery, except with newborns. With newborns, you may be conducting an ABR, an auditory brainstem response, a diagnostic auditory brainstem response test in place of pure tone audiometry if you're trying to find frequency-specific thresholds for a newborn or an infant that's under 6 months old. The key thing with pure tone audiometry is it requires cooperation of the patient, and it is a ubiquitous part of testing since the mid-1900s. It's used to describe the amount of loss, site of lesion, need for medical referral, and predict a patient's ability to listen and communicate. Standard thresholds that we test, I mentioned, are 250 to 8,000 hertz. We rarely test at 125 hertz, but we do sometimes test that frequency with what we call corner audiograms. That's oftentimes when you have moderate to severe hearing loss in the mid to high frequencies, and we have some hearing loss in the low frequencies as well, but we have better hearing in the low frequencies. We might want to measure at 125 hertz to better characterize hearing loss. We might also measure extended high frequencies from 10,000 hertz up to 16,000 or 20,000 hertz. Historically, it's been used for ototoxic monitoring, but it's also been used for tinnitus assessments or for cases of hearing loss when there is reported deficits, but you have normal pure tone audiometry in the conventional audiometric range. There is an important thing to note here, the limitation of ecological validity. Most real-world sounds are not pure tones and quiet. The test does not fully represent daily life, hearing performance. Most real-world sounds are complex at moderate levels and in background noise. So again, our intention is not to measure hearing at a realistic environmental setting. Our intention is to measure hearing in a standardized way to measure the loss of audibility. Hearing depends not only on one's ability to process frequency, intensity, and temporal parameters of sound, but also on non-acoustic factors like auditory system maturation, cognition, motivation, and context. So why do we use pure tones as a stimulus in general? We do it because it's easy to generate and easy to calibrate. Hearing loss can differentially affect hearing at different frequencies. By understanding the frequency-dependent nature of a person's hearing loss, we can predict how much of speech will be audible under various conditions. So like I said, we're not measuring hearing under realistic circumstances, but we can make predictions based on pure tone audiometry, even though it's not what we're actually measuring. Actual testing hearing does require a skill set that is acquired with experience. You're going to get better at testing as time goes on. You're not going to be an expert at it right away. Certain types of hearing loss are more likely to affect high frequencies. Think noise-induced hearing loss. Some types of hearing loss affect mid-frequencies. Think of a cookie bite hearing loss configuration, which is often genetic, or low frequencies. Think of Meniere's disease as an example. The need for skill in audiometric testing is especially true with children between 6 months and 4 years of age, in elderly adults with dementia, and in patients who are feigning a hearing loss. Here's an example of pure tone audiograms with a speech banana superimposed on top. When I say speech banana, it's that yellow-shaped curve that looks like a banana. It shows where all the phonemes or the speech sounds of American English lie on top of an audiogram at an average conversational level spoken by an average person. You can see some of these speech sounds fall within the low frequency region, some fall within the high frequency region. We see vowels like O, E, Ah, those are low frequencies. We see fricative consonants like F, TH, and S, those are high frequencies. Those are also softer. Some sounds like O, Ah, and E, those vowels are louder in intensity. We know they're louder because they're lower on the audiogram. We know the F, the TH, and the S, those fricative sounds, those are higher on the graph, indicating they're softer, and they're farther to the right, indicating they're higher in frequency. We see an audiogram superimposed on top. The red for the right ear, the blue for the left ear. On the left graph, we see hearing thresholds that are normal. And they're normal because we can also see that all of these speech sounds, all of these phonemes in American English fall below the curve, indicating that they're audible at a normal conversational level. But if we look at the audiogram on the right side, we see that some of these phonemes, F, TH, and S, are falling above the curves, above the blue and the red curves, indicating there is some degree of hearing loss here. High frequency hearing loss of mild degree. There are different types of audiometers. There are actually five types of audiometers. Five types of audiometers that we have, and these are outlined by the American National Standards Institute, otherwise known as ANSI. Their ANSI committees form, ANSI forms committees that generate these industry standards for these five different types of audiometers. We have an advanced diagnostic audiometer, type 1, type 2 is a diagnostic audiometer, type 3 is a simple diagnostic audiometer, type 4 is a screening audiometer, and 5 is the simplest type of audiometer. Type 1 has 4 transducers available, 4 transducers being insert earphones, supraoral earphones, insert earphones, and then a headphone like circumoral or supraoral, sound field speakers, and a bone conduction oscillator. So that's 4 transducers. You can measure from 125 to 8,000 hertz via air conduction, and you can measure 250 to 4,000 hertz via bone conduction. There are different maximum levels across different transducers and across different audiometers. The Type 4 audiometer only has one transducer, like super oral headphones, and with frequency range of 500 to 6,000 hertz, maximum output level of 70 dBHL at each frequency. Type 5 has no minimum or maximum capability specified. The test environment. So we want to think about the environment that we're testing the patient in. So audiometry is conducted oftentimes in sound-treated booths, but not exclusively in sound-treated booths. It can be conducted in a quiet room, but sound-treated booths have been the historical norm. And there are ANSI standards that specify the maximum permissible ambient background noise levels for audiometry testing. Test booths can be either single-walled or double-walled. Double-walled is like a room within a room. The purpose is to isolate from outside noise. And then the way you face the patient, either towards or away from you, depends on your purpose. If you want to face them away from you, that's so they don't get visual cues from you pressing the button on the audiometer. If you want to face them towards you, it's usually during speech audiometry, so you can read their lips when they're responding to word recognition testing. So a lot of times a 45-degree angle perpendicular to the tester is a good compromise in general. So we have to be mindful of visual cues, and be mindful for audiometry, and be mindful of visual cues for speech audiometry. And we also need to think about visual cues when we're testing babies, visual reinforcement audiometry. We need to make sure the baby doesn't see us and focus on us. We want them to focus on the assistant in front at 0-degree azimuth, or on the toy reinforcer at 45 degrees or 90 degrees azimuth. So here's an example of the test environment, some different types of test rooms. We have walls that are about 4 inches thick. We can be a single-walled booth like you have on the far left, and on the far right, those are like phone booth type booths. On the far left, you can see that one is on wheels to be portable. In the middle, you see a double-walled room where you have a one room for the tester and one room for the patient. So again, that's like a room within a room. With the advent of sound level meters built into modern computerized audiometers, boothless testing is becoming more common. Think mobile audiometry clinics, like for example, you can see this in some VA compensation and pension exam vendors. You can see this in nursing homes. You can see this where people are testing in patients' houses. So it's becoming a little bit more common not to use a test booth, but it's still the norm in general. If you work in an ENT clinic, you're going to be testing with a sound-treated booth. If you work in a speech and hearing clinic at a university, you're going to be testing in a sound-treated booth. If you work inside a VA, you're going to be using a sound-treated booth. So audiometers, let's go over briefly different types of audiometers here. They have similar functions and components. Some models are missing certain features. These pictured are all diagnostic audiometers with 2 channels. They must conform to ANSI standards. In other countries, they must conform to ISO standards. ISO stands for International Standards Organization. Many audiometers can save the data internally in a computer and or externally to a computer database like NOAA. Most audiometric equipment manufacturers are owned by William Demant, which is the maker of Oticon hearing aids. Only one major manufacturer is no longer owned by William Demant. That's just kind of a side note, nothing critical about that. But I thought I'd just mention the consolidation of the industry. There are computer-based models for audiometers where you may only have a box where you have plug in your headphones, microphones, and response button where that they plug into there. And you may also have a specialized hybrid unit like you see on the right side that feels a little bit more like a traditional audiometer but uses a computer screen. And it's actually a computer-based audiometer. It just has the feel of a traditional audiometer. The benefit of a full computer integration is portability, ease of storing data in NOAA to use with hearing aid or implant fitting software, and report writing. So computerized audiometers are starting to become a bit more popular, but the standalone audiometers are still very popular because people are resistant to change, and there certainly is better reliability, in my opinion, with the standalone audiometers. Other types of audiometers include automatic audiometers. Bekasi audiometry was the first type of automatic audiometer that adapted signal level based on patient response. These may be used in industrial settings, in military settings. So Bekasi audiometry, that type of audiometry automatically increased the intensity level until the subject responded by holding down a button. And then you would see that the tone on a tracing, like on the lower left corner here, the tracing would decrease in intensity when you hold down the button, indicating the patient can hear the tone. And then when you release the button again, because you no longer hear the tone, it increases in the tracing. If you work as a VA compensation and pension examiner, you can still see some old Bekasi tracings, but these have become less common as time goes on and veterans pass away, and the Bekasi tracings are no longer as commonly seen in these case histories, in these medical service records, in these veteran service records. Bekasi tracings historically were even used as site of lesion testing, classified into tracings type 1, 2, 3, and 4, with type 3 and 4 tracings where you're comparing continuous tones versus pulse tones. They found that with continuous tones that they were much worse than with pulse tones, and that was seen in eighth nerve disorders, but this test was not sensitive enough compared to subsequent tests later on, like ABR testing, for example. Here's a newer modern type of automatic audiometer called an AMTAS system. It works in conjunction with a AudioStar Pro or Pello audiometer. It's backed up by 15 years of research and development, heavily led by Robert Bergolas, a famous research audiologist. We've seen large rollouts in Costco recently. These GSI AMTAS Pros are designed to have minimal supervision by a hearing instrument specialist or an audiologist, and you can test multiple patients at the same time. And it's designed to be all self-driven. There are some benefits of these self-driven audiometers. There's less human bias involved, so that is one potential benefit. But you have to supervise them and make sure that the patient is responding appropriately. So that's one drawback of these GSI AMTAS audiometers. You also have these screening audiometers that are very small and portable, much more limited in capabilities. They're single channel, no bone conduction, only one set of transducers like supraoral headphones, often used mainly by speech pathologists, school nurses, or primary care physicians. Basic functions of pure tone audiometers include they produce pure tones at selected frequencies. That would be the oscillator. You can change the intensity of the signal with the attenuator, and you can select how the signal is delivered to the ear. That's by selecting the different transducer. And you can direct the signal to a desired location via the routing function. For example, a tester would set the oscillator to 1000 Hertz, the attenuator to 30 dB HL, the transducer to insert earphone, and the routing to the right ear. When ready, the tester would hit the present button, and the patient would indicate a response by pushing a button, raising their hand, or just saying yes. basic functions of pure tone audiometers. Pure tone audiometers, this is kind of getting as an aside, have speech audiometry capabilities involved. So this is not really pure tone audiometry, but pure tone audiometers have speech audiometry functions built in, and as part of the speech audiometers, they have a VU meter. So when you're talking and you're presenting words into the speech audiometry function, you're trying to hit 0 VU, 0 volume units. Then that means that the target you have on your audiometer, say 65 dBHL, is actually what it says at 0 VU. On the left, you have an old school analog VU meter. On the right, I know it's a little bit blurry, that's a screenshot of a more modern VU meter on my clinical audiometer from work. You can see that it doesn't have nearly as many numbers outlaid on it. But getting back to the basic functions of a pure tone audiometer, diagnostic audiometers have 2 channels. Since some tests require different signals presented to each ear, most commonly a signal to one ear and masking noise to the other ear. Sometimes you can accomplish that with what's called the 1.5 channel audiometer, but you need a 2-channel audiometer if you're presenting different signals to each. Well, I take that back. If you're presenting truly different signals to each ear, like dichotic listening is an example where you need a 2-channel audiometer. Dichotic listening, where you might be presenting pairs of numbers to one ear and a different pair of numbers to the second ear. That's an auditory processing disorder test. That's when you might need a 2-channel audiometer. Basic components of pure tone audiometers. You can use the frequency selector to select the frequency of the pure tone. You can use the attenuator dial to change the sound pressure level of the signal. You can use the transducer selector to select how the signal is delivered. Are you delivering it to the sound field? Are you delivering it to the insert earphones? You can use the router switch to direct it to the desired location, like the right ear versus the left ear. Use the interrupter switch to present the signal to the patient. Use the patient response indicator to let the patient lets you know when they hear the tone. And the VU meter monitors or calibrates the input level. This is an example of a screening audiometer and different functions on the screening audiometer. You have the attenuator dial on the far left. You have that router switch for right and left ear on the top. You have the transducer selector indicated by that button that the arrow is pointed to. Frequency selector labeled in hertz. And the interrupter switch, which is that big dark gray button in the middle with a loudspeaker icon next to it. A transducer, I've mentioned transducer already, and I've described them as different types of earphones, but I haven't defined what a transducer is. A transducer converts one form of energy to another. For our purposes, a speaker or receiver is going to convert electrical energy to acoustic energy. And for transducers, they're going to be right ear or left ear. Right is always labeled red and left is labeled blue. Always make sure the earphones are on the correct ears and the router switch is set correctly. Don't feel bad if you have left-right confusion and you have a mix up left and right ears. It's a very real thing that's documented in the psychology literature, and it's plagued many audiology students over the years. It's an easy error to make because when you're looking at the patient, they've got the right earphone on the left side and the left earphone on the right side. It's a mistake that's easy to make, but it's one that you never want to make yourself. So you want to be cognizant of placing the earphones correctly. Different types of transducers used in pure tone audiometry. We have insert earphones, supraoral earphones, circumoral earphones. We have loudspeakers. We have bone conduction vibrators. The traditional model numbers are listed out here, and the newer models are listed out here as well. The ER3A is the most common insert earphone. Replaced by the IP30. It's really identical. And then we have supraoral earphones. The TDH models are all a little bit different, but they're being replaced by the Radio Ear DD45, a little more comfortable. Sennheiser HTA 200 is the classic circumoral earphone, being replaced by the Radio Ear DD450. It looks almost identical. And then for the loudspeakers, they come in all sorts of makes and models. And then we have the bone conduction oscillator. The Radio Ear B71 is being replaced by the B81, which has a better frequency response, and it has greater output levels. Now I want to talk about the different type of transducers. First, we'll talk about insert earphones. These are the compressible, disposable foam tips that fit in the ear canal. First introduced in the mid-1980s with widespread use at present. These were a huge innovation because of the problem with collapsing ear canals with supraoral earphones. So supraoral earphones would cause collapsing canals in the elderly population in up to about a third of patients. You can see pictures of the insert earphones in the bottom left corner here. The bottom left corner you see 406A, which is a standard adult-sized earphone, 406B, which is the pediatric earphone, and 406C, which is an extra large insert for someone who had surgically altered ear canals. And then in the middle picture on the bottom, you see that they're connected to a pair of Eartone 3A, a common type of insert earphone. And then you can see them placed in a child's ear canal on the far right, on how they're attached to the shoulders of the shirt and how they come out. And they are easy to use with head movement back and forth, like you oftentimes see with visual reinforcement audiometry or any kind of audiometry where head turns are a relevant role. Here you see the insert earphone placed in mannequin ears, and you also see it placed on an adult ear as well. Again, the Eartone 3A being a common model, designed to test hearing from 125 to 8,000 hertz, with the maximum output is about 15 to 20 dB lower than supraoral headphones, but interoral attenuation is greater, leading to less need for masking and overcoming the problem with collapsed canals like I alluded to a moment ago. The electroacoustic diaphragms are housed in a small plastic casing that you place on the shoulder, and the tubing connects to a foam insert conformed to the ear canal with your fingertips and inserted into the ear canal like a foam earplug. So the inserts are disposable for hygienic reasons, obviously. Here's a picture of the different degrees of insertion. So here you have an intermediate insertion, which is probably the most common, where you have the foam insert tip is flush with the ear canal entrance or slightly sticking outward. This is, in my experience, the most common insert depth. It's not the ideal. The ideal is the full insert depth, about 2 to 3 millimeters inward. There you can see that the insert ear foam tip is in the cartilaginous canal, but just at the juncture of the bony canal. You'll increase interoral attenuation by doing so, but oftentimes it might be uncomfortable, or you might just not be able to physically fit it in deep enough because of the angle of the ear canal. And then on the bottom right, you have a shallow insertion. When you have a shallow insertion, this is when you should reconsider insert earphones. You should probably consider something like a circumoral earphone instead. With a shallow insertion, you have reduced interoral attenuation and potential for leakage in the low frequencies where you might have a false air bone gap at 250 hertz. So sometimes you can't control the insertion depth due to patient anatomy or comfort. smaller pediatric inserts do not seem to solve the problem entirely. So what I mean by that is if you had a shallow insertion in an adult, you might think, well, let me use a smaller pediatric insert. And the pediatric insert will sit in deeper, no doubt about it, but it doesn't necessarily give you a better acoustic seal. That's been my experience. Here's your standard supraoral headphone, both in picture form and on a patient, a female patient here. Oh, let me go back here. I guess that's all I had for supraoral headphone here. So the standard earphone is used until inserts were developed. It's still used in some situations like narrow older adult ear canals where an insert foam tip is causing a low frequency air-bone gap artifactually, and the foam ear tip is and its greater output is needed than an insert can provide. It's a better choice for TM perforations due to a more accurate representation of the audiogram. There have been studies that have looked at the sound pressure level around the eardrum with a perfed eardrum when you compare insert earphones to TDH supraoral earphones, and you have a better, more accurate representation of the sound pressure level when you use supraoral earphones. Another reason you might use a supraoral earphone is if you have a draining ear. So an ear with, say, a perforation, and you have fluid draining from the ear, you wouldn't want to get that into your insert foam ear tip. So that's another example where you might use a supraoral earphone, or if you have a patient who has anxiety about anything being inserted into their ear canal. So the supraoral earphone sits on top of the pinna. It was the default earphone before the development of the inserts. Still very popular, just not as popular as it used to be. The diaphragm is at ear level, covered by a rubber cushion, which is replaceable fairly inexpensively, but it's rather uncomfortable and either not centered adequately on the patient's ear or causing collapsing canals may result in erroneous hearing thresholds that are higher than they should be. Slightly higher output than inserts is the benefit. It should be used with patients who have active drainage, profound hearing loss, or atresia. So when I say atresia, I mean ear canals that are not present. If you have to test hearing, if you work in a pediatric audiology setting or a hospital setting, and you have to test a patient with atresia, and supraoral earphones are the way to go. You cannot use insert earphones. And then for hygienic purposes, covers for supraoral headphones and circumoral headphones do exist. They fit better on supraoral headphones, but they can fit on circumoral headphones just fine. The circumoral headphone is essentially a hearing protector earmuff with a transducer built in. It surrounds the pinna. It's far more comfortable than a supraoral headphone, and it has the benefit of being able to extend to be able to test into extended high frequencies if you have a software module that allows you to do that. Like everything else, you pay extra for features, and that is the extra feature that you pay for if you want to test up to 16,000 or 20,000 hertz. So the circumoral headphone, like I mentioned, surrounds the pinna and is used for extended high-frequency testing. It's becoming an increasingly popular replacement for a supraoral headphone, but the big limitation is the speech channel. So I know we're talking about primarily about pure tone audiometry, but for speech audiometry, the limitation is that you cannot exceed 90 dB HL output for a circumoral headphone. At first, I thought this was just my audiometer, but I've experienced it on other audiometers as well, so I've realized that it's a limitation of the earphone and not the audiometer. Extended high-frequency testing, historically used for ototoxic monitoring, but increasingly used for tinnitus, DPO and otoacoustic emissions assessments, and speech and noise complaints with a normal audiogram. Here's an example of supraoral headphones directly compared to circumoral headphones. I didn't know this until I looked it up. Study conducted by Flame et al. 2015, published in the International Journal of Audiology. It looks at the standard deviation of the responses for different frequencies. And so what we find here in comparing the TDH39P supraoral to the HDA200 circumoral is that we have a superior high frequency reliability with the circumoral, such as the Sennheiser. So test-retest reliability is better than a traditional TDH39P supraoral headphone. So that reliability advantage is most pronounced in the high frequencies at 6 and 8K. So that's partly because you're mitigating standing waves. Traditional supraoral headphones rest directly on the pinna, and their reliability degrades at high frequencies where short stimulus wavelengths can cause standing waves in the ear canal. Circumoral earphones seal around the periphery of the pinna without resting on it, reducing these acoustic anomalies, but they still are present in circumoral headphones. You also have ambient noise benefit with circumoral earphones, offering better ambient noise attenuation than supraoral models, which is an important consideration for testing outside of standard clinical booths. If you're doing boothless testing, you should be using either a circumoral or an insert earphone, not a supraoral earphone. So sound field speakers, used for some pediatric testing and used for hearing aid testing. Results are not ear specific. That's the key thing to be aware of, especially in pediatric testing. Not ear specific. Even if you have them positioned in different corners of the room, often positioned at 45-degree angles, 45-degree azimuth, if you position them in the corners, it's not ear specific. A right speaker is not testing the right ear, and a left speaker is not testing the left ear. Yes, you have a head shadow effect, but the better ear is being tested. So sound field testing, or more accurate, is the more accurate term, but sometimes they call it free field testing, which is a less accurate terminology, but used almost synonymously. There are many different models of sound field speakers used for testing pediatrics where they cannot tolerate earphones, or if you're testing in the aided condition, like aided versus unaided with hearing aids or cochlear implants. That's another example where you use sound field testing. There are limitations of sound field speakers in that it's not ear specific, so the response represents the better hearing ear. If a patient has asymmetric hearing loss and you need to test that aided performance in the worse ear, an earphone with masking noise can be used in the better ear. Ideally, pediatric patients would be tested with insert earphones, but that doesn't always work out in practice when they're too young, when they have hypersensitivity to touch, kind of like children with autism, for example, may not always work out to use headphones. They may be resistant to it for kids. Now we have transducer, we have the bone conduction vibrator. The vibrator or oscillator is placed behind the ear on the mastoid, in particular the petrous pyramid of the mastoid. Should not touch the pinna. Emphasize, should not touch the pinna. It can be close, and that's the same as the auricle. I know I'm using it interchangeably here. Pinna and auricle are the same thing. We're trying to find the lowest intensity output limits, we have lower intensity output limits with bone conduction transducers than we do with air conduction transducers, so there are some limitations with bone conduction transducers. Another limitation is that when we stimulate the ear via bone conduction, we're stimulating the better hearing ear. Actually, we're vibrating other locations on the skull, the forehead, and the teeth. That would also stimulate the cochlea in both ears. and those can be actually more, teeth, for example, can be more effective at stimulating the ear. There actually was a bone conduction hearing aid called the Soundbite that delivered the stimulus to the teeth for single-sided deafness. I fit all of one patient with it. He loved it, but the company went out of business. It was a really interesting product. It required a BTE-style hearing aid and a custom-made mouthpiece by a dentist where the vibrator would be on the tooth itself, on one of the molars. So air conduction masking is needed to deliver to the non-test ear so that ear-specific results can be obtained from the test ear. Testing from 250 to 4,000 hertz. Output limits are frequency specific, but usually limited to about 75 to 85 dBHL at their max. The max is going to be lower at low frequencies, partly because of vibrotactile thresholds. So the newer B81 transducer does have higher output limits, but we still have vibrotactile responses at the same levels. And that's frequently encountered with 250 hertz. You can also encounter vibrotactile stimulation with 500 hertz. What I mean by vibrotactile stimulation is you can feel the response instead of hear the response, and the patient is not always reliable at telling you which is which. So that's something to be aware of. Here's a graph I made out of the paper from Jansen et al. It's a mean of 16 deaf cochlear implant patients. So totally deaf, they're not wearing their cochlear implant. What they wanted to do here is to find out what are the vibrotactile thresholds for two things, the B71 and the B81 bone conduction transducers, the older and the newer type of bone conduction transducers. And they also wanted to find out what is the difference between forehead placement and mastoid placement for the transducers. So I know we've mainly talked about mastoid placement for the transducers, but it is becoming increasingly common to test bone conduction on the forehead instead of the mastoid. There are some benefits to testing bone conduction on the forehead. One benefit is you don't have to run back and forth between the booth where you're having to move from the left to the right mastoid. You just have it on the mastoid. You cover yourself, you cover the ears with circumoral earphones, and you're good to go. You can just do your whole test without running back and forth. But you can see a clear limitation here when you compare forehead to mastoid vibrotactile thresholds. We can see the threshold level for the mastoid is at a higher level than the threshold level for the forehead. That means you get vibrotactile thresholds at a lower level using the forehead. So that's a clear drawback to using the forehead compared to the mastoid. So, advantages and disadvantages to each style of transducer, but the forehead is becoming more common. Now, bear in mind, if you're calibrated to a mastoid, you can't just switch it over to the forehead. There are different reference calibration standards. So the technician that calibrates your equipment has to be the one that calibrates it accordingly. And these references that I'm putting up in slides here, if you want to read them, they're in the supplemental materials section on Blackboard. Now I want to talk about something very different in bone conduction audiometry. As you may be noticing, there are problems with bone conduction audiometry, things like vibrotactile thresholds, things like a limited frequency range going from 250 to 4,000 hertz, things like having a lower output level max. Well, here's another problem with bone conduction audiometry. It's what we call the false 4,000 hertz air-bone gap. And here's a study. This study is not quite as meaty. This is a little bit easier study to read from Audiology Today, a trade journal magazine on Blackboard. So the phenomenon here is audiograms for patients with pure sensory neural hearing losses show non-pathologic airborne gaps between 10 and 20 dB on average, isolated to 4,000 hertz. The compounding clinical error is the issue here. The magnitude of the false airborne gap is not static, it's not linear. It artificially increases as the patient's underlying 4,000 hertz hearing threshold worsens. So you can see here in this study, we've got a study by Wasserman, Altus, and Margolis. So let me talk about these for a moment. So the study by Altus here on the right is just when you have bone conduction thresholds between 0 and 5 dB. And that's pretty straightforward, that airborne gap. But the key thing here, the Margolis study versus the Wasserman study, the Margolis study is automated using the GSI AMTAS system. In comparison, the Wasserman study was using manual audiometry. So what this tells us is that if you have a human tester using manual audiometry, they will intentionally or unintentionally make that airborne gap smaller because they know in their mind it should be about 10 dB. Even at 4,000 hertz, we see airborne gaps around 14 dB, but they're really about 20 dB when you use an automated system. And you can see there's a systematic increase in airborne gap size as we move up in hearing threshold level. So there is human bias inevitable to testing when it comes to these airborne gap situations. Here's an example of this false airborne gap and why it occurs. This is referencing the same study. So current ANSI and ISO standards, remember ANSI standards are the US, ISO standards are international, they're in line with each other. There's not a big difference between these standards. They specify a 4,000 hertz reference equivalent threshold force level. It's just the correction factor that moves from dB Ray 1 micronewton to dB HL. They specify a correction factor that is frankly incorrect for 4,000 hertz. It's an old study by Corliss from 1959 that showed that in bone conduction audiometry, there's a constant acceleration of negative 12 dB per octave. And we see that in the data itself by Corliss, and we see it in a pure curve, negative 12 dB per octave. But we see the retfolds, these correction factors that convert dB SPL, I guess you can say, or dB in force to dB HL. You can see that there's this gap of 14 dB, which shouldn't be there. And those are incorporated into the standards for various reasons. So what to do? So first, the diagnostic impact. Reporting these false gaps without correction risks misinterpreting the loss as conductive, leading to unnecessary medical referrals, imaging, or surgery. Now bear in mind, ENTs are not always going to be familiar with these false airborne gaps. Hearing instrument specialists are definitely not familiar with false airborne gaps at 4,000 hertz. Audiologists, not even all audiologists are familiar with this. So I'm trying to educate you today on this information, which is incredibly clinically relevant. It's so relevant that the British Society of Audiology has taken out 4,000 hertz in their bone conduction protocol. They just stick to 500, 1,000, and 2,000 because of the 4,000 hertz debacle. I personally try to use 3,000 hertz. There's still a gap, but it's not as bad as 4,000 hertz. I think it's a reasonable compromise rather than not having any high frequency threshold. That's just my personal take on it. there's flaws to 3000 hertz too. My personal take is give it a try at 3000 hertz. So for air conduction testing versus bone conduction testing, the whole point here is to differentiate the components of the middle ear, the conductive portion of the hearing loss versus the sensory neural portion of the hearing loss. The conductive portion of the hearing loss is the outer ear and the middle ear. So the middle ear is probably pretty straightforward for you. We've got middle ear fluid, we've got bones that aren't vibrating because of fluid in the middle ear. We've got bones that are disarticulated, so they're not doing their job appropriately. And we've got portions, sensory neural portions of the hearing loss, which would be the inner ear, the eighth nerve, and the central auditory nervous system. So bone conduction testing bypasses mostly, not entirely, but mostly bone conduction testing bypasses the conductive portion of the hearing loss. And that's our goal for bone conduction testing. So the way bone conduction testing bypasses the middle ear and outer ear is by delivering vibrations directly to the inner ear. The difference between air and bone conduction test thresholds is the air-bone gap. So if you take the air conduction threshold and you minus the bone conduction threshold, that is your air-bone gap. If you do it in the opposite direction, bone conduction minus air conduction, that would be a negative air-bone gap. They call it a reverse air-bone gap in the book, but I call it a negative air-bone gap. Either way, it's not clinically relevant. It gives you an idea if there is non-organic hearing loss, if someone's feigning a hearing loss. It gives you an idea about calibration problems or placement problems with the transducer, but it's not clinically meaningful. Negative air-bone gaps don't clinically mean anything. Sensory neural hearing loss is caused by the inner ear, eighth nerve, and central auditory dysfunction. Equal air conduction and bone conduction threshold elevation is associated with sensory neural hearing loss. Conductive losses show normal bone conduction thresholds, but elevated air conduction thresholds. So normal bone conduction thresholds, elevated air conduction thresholds, that is a conductive hearing loss. Mixed losses show elevated air conduction thresholds and elevated bone conduction thresholds, but the air conduction thresholds are worse than the bone conduction thresholds. So worse air conduction thresholds than bone conduction thresholds, but both are elevated. That is a mixed hearing loss. There are different types of losses possible at different frequencies. You can have a mixed loss at one frequency, sensory neural loss at another, and then normal hearing at another, or conductive loss at another. So you can mix and match different types of hearing loss for a given audiogram. Sometimes bone conduction can be worse than air conduction, but not usually by more than 5 to 10 dB. And it's not clinically significant. These negative air-bone gaps are not clinically significant. As I mentioned before, it can be from placement issues, it can be from malingering or feigning a hearing loss, but it can also just be from statistical variability, because air conduction and bone conduction thresholds are independent variables. You can, just by random chance alone, have an occasional bone conduction threshold that's worse than air conduction thresholds. And that's okay. Just document it how it comes out. So procedures for obtaining pure tone thresholds here. We have standardized protocols that have been developed by ANSI and ASHA in the US. The ANSI protocol is newer from 2019. The The ASHA protocol is from 2005. You'll probably find the ASHA protocol is more popular. Why is it more popular? Because with the ASHA protocol, you can access it fairly easily. I'm not even sure if you need a membership to ASHA to access it. Even if you do, many audiologists have memberships to ASHA. To get the ANSI protocol, you have to be a member of the Acoustical Society of America if you want a free copy of it, and not that many audiologists are members of the Acoustical Society of America. So, why do we care about procedural variations from audiologist to audiologist? Standard procedures are based on modified Hewson-Westlake procedures, 5 up, 10 down. Variations exist, but much of the core of these procedures is all very similar. You want to provide the instructions to the patient, such as we are interested in finding the faintest sound you can hear at different pitches. Listen carefully and be sure to press the button as soon as you think you hear a sound and release the button as soon as it goes away. We will be testing each ear separately. Do you have any questions? That's one example of instructions you can give. You want to test 125 hertz, mainly to better characterize low frequency hearing loss. But you'll struggle to impact. It will have negligible impact on hearing aid settings. 125 hertz is going to be not really relevant to hearing aid settings, and that's because hearing aid ear molds and domes are vented, so you're not typically amplifying at 125 hertz. So it's not going to be a big deal. So after you provided instructions, you place the transducers, typically yourself, although there is research to show that patients can place the transducers. I mean headphones, I don't mean insert earphones. They can place the transducers themselves and have accurate results. You do air conduction testing before bone conduction testing, and you start in the better ear if known. If you don't know the better ear, you start in the right ear. Why the right ear? Just because you have a standard. You select the test frequency, starting with 1,000 hertz. Frequencies tested include 250, 500, 1,000, 2,000, 3,000, 4,000, 6,000, 8,000. So basically, octave frequencies between 250 to 8,000 hertz. Plus, it's good habit to test 3,000 and 6,000 hertz, both because of noise notches and because for hearing aids. You test 750 and 1,500 hertz when their interoctave frequencies are greater than at least 20 dB or greater. You can see the exact order of frequency testing in the textbook. Retest 1,000 hertz the first time. You don't need to retest 1,000 hertz on the second ear. On the first ear, you retest 1,000 hertz because of familiarization, and you oftentimes might get a 5 dB better threshold. No 8,000 hertz or 6,000 hertz for bone conduction testing, just up to 4,000 hertz. And then you want to ask the patient to press and release the interrupter or the response button. Let me rephrase that. You want to press and release the interrupter on the audiometer to present the pure tone. Either a pulsed or a pure tones are fine. Pulse tones have a shorter duration, but you might have 3 or 4 pulses per presentation. Total duration of tone is about 1 to 2 seconds. Interstimulus intervals, or the pauses between tones, should be about 1 to 4 seconds. That gives the patient enough time to respond to the tone. Some patients respond quicker than others. You'll get a general sense for this and adapt your procedure accordingly. You want to begin with familiarization, starting at 30 or 40 dB above estimated threshold. If no response, then increase in 20 dB steps until you get a response. Then you decrease in 10 dB steps until no response. Now the threshold search begins. A couple other things to note. Pulse tones that I mentioned earlier can be helpful in patients with tinnitus because they're easier to distinguish from the ringing in the ears. Alternatively, an ascending procedure can be used when one starts at the lowest intensity level and gradually increases until you get a response, and then you decrease by 10 dB. That's a good procedure if you're worried about non-organic hearing loss, like you might have in the VA or a work comp claim. So you use the up 5, down 10 dB paradigm. When a patient does not respond, you increase intensity by 5 dB. When a patient does respond, you decrease intensity by 10 dB. This is an ascending threshold procedure. Keep track of patient responses in your head. It's not that hard to do. Continue searching until you have found the lowest level at which the patient responds at least 2 out of 3 times when ascending. You could choose 2 out of 4 times if you want. That's up to you. 2 out of 3 is a little quicker oftentimes. The plus sign here, here's an example of, let me double check to make sure I didn't miss anything. Yeah. Here's some examples of threshold responses. Let me go through some of these with you here briefly. Some of the key points about these 3 examples here. The plus sign represents a patient response, and the minus sign is no response. Threshold is the lowest level, which patient responds 2 out of 3 times. After each response, signal is decreased by 10 dB, but after a response, it's increased by 5 dB, and then the threshold is circled. Here in example A, presentation level started at 30 dB, and the patient responded. So that means that we want to lower the response. We want to lower the presentation level by 10 dB. So trial 2, we present at 20 dB. Patient responded again. So that means we lower again by another 10 dB for trial 3. Now the patient does not respond. So now we're thinking the threshold is going to be between 10 and 20 dB. So now we increase by 5 dB in 5 dB steps. So the first to 15 dB for trial 4, and the patient did not respond. Then we moved up 5 dB to 20 dB for trial 5. The patient did not respond. At this point, there has been one ascending series with a response at 20 dB and no response at 10 dB or 15 dB. Trials 6 through 8 showed a similar response pattern following the rule of lowering the level by 10 dB following a response and increasing the level by 5 dB when there's no response. The second ascending series ended with a second response at 20 dB and no response at 10 dB or 15 dB. However, there was still the possibility that 15 dB could be the threshold if the patient were to respond at 15 dB for 2 more ascending series to satisfy the criterion that the patient had the opportunity to obtain at least 50% of presentations out of a possible of 4 presentations. So it can be out of 4 as well. So trials 9 through 11 showed the third ascending series in which the patient did not respond at 15 dB and did respond at 20 dB 3 out of 3 times. And so trial 11 technically would not have been required because it would have already been determined that the best score out of a theoretical 4 presentations that the patient could achieve at 15 dB would be 25%. And even if they did not respond at 20 dB in the third trial, they would have satisfied the criterion of 2 out of 3 at this level. However, this last trial at 20 dB would usually be included to complete the series. In this example, the patient again responded at 20 dB, thus the patient's threshold would be 20 dB. Now we've got figure B. In figure B, we're starting out at 30 dB. Patient didn't respond, so we're jumping up to 50 dB, 20 dB higher. And so at 50 dB, the patient did respond. Since patient responded at 50 dB, we dropped it down to 40 dB. No response, so we increase in 5 dB steps to 45 dB. We got a response, dropping it down to 35. No response, increasing it to 40. Then we got a response, dropping it down to 30. We got no response there. So we increased it to 35 dB. No response again. We increased it to 40 dB. Got a response, decreased to 30. Got no response, increased it to 35. And then no response, increased it to 40. Where we got a response. So we got three responses in ascending series. So for a threshold at 40 dB. Lastly, in C, we started at 30 dB, and then we got a response. So we dropped it down to 20 dB. We got a response, dropped it down to 10 dB. No response, got to 15. No response, got to 20. No response, got to 25. We got a response, dropped it down to 15. No response, got to 20. No response, got to 25. Got a response, dropped it down to 15. Got no response, presented at 20. Got a response, dropped it down to 10. No response. Now we're at 15. No response. Now we're at 20. No response. Now we're at 25. Got a response. That's the third ascent where we got a response at 25 dB. That is our threshold. So other variables that influence thresholds: pure tone detection thresholds or a behavioral test. So it depends both on patient sensory capacity and response criterion. So for the physical world, this represents the objective reality where a stimulus either is present or absent. In any environment, there is always background noise. The signal is the specific physical energy, like a pure tone or a speech stimulus, that is introduced into this noisy environment. We've got internal processes represented by the oval here. The core of the theory posits that translating a physical stimulus into an observable response requires two separate internal mechanisms: a sensory process and a decision process. The sensory process involves the observer's sensory system receiving the physical input and translating it into neural activity. This internal representation is continuous and inherently noisy due to spontaneous neural firing and physiological variables. The strength of the sensory evidence determines the biological detectability, often represented mathematically by D prime of the signal. Now we've got the decision process. Once the sensory information is processed, it moves to a cognitive stage. The observer evaluates the sensory evidence against an internal threshold or criterion referred to as beta. If the internal sensory response exceeds this established threshold, the observer decides the signal was present. If it falls below the threshold, they decide it was absent. Now for response behavior. This is the overt, observable action taken by the individual based on their internal decision. In a clinical testing setting, such as patient completing a hearing evaluation or a speech and noise test, this is the moment the patient presses a button or verbally confirms they heard the stimulus. Because the response relies on both the physiological sensory process and the cognitive decision process, the final behavior can result in one of four distinct outcomes. There is a hit, the signal was present, and the observer correctly reported it. There is a miss, the signal was present, but the observer failed to report it. There's a false alarm, the signal was absent, but the observer incorrectly reported hearing it. And there's a correct rejection, the signal was absent, and the observer correctly reported nothing. The model demonstrates that an individual's behavioral response is not solely dictated by their physiological sensitivity, but is equally influenced by their decision-making strategy. whether they're a conservative responder who waits for absolute certainty or a liberal responder who guesses at the slightest sensory fluctuation. That's the breakdown. We also have variations with young children or difficult to test populations. While the auditory system is mostly developed at birth, developmental changes are undergone until age 4 or 5. These affect pure tone audiometry. Motivation is key. Verbal praise is one example of motivation. An assistant can be helpful. Not always practical, but an assistant can be helpful for testing pediatrics. Test with earphones if you can, speakers when you must. Use frequency modulated or warble tones or narrowband noise instead of pure tones when you're testing in the sound field. A new alternative is called fresh noise, which are like narrowband noise with tonal characteristics due to steeper frequency cutoff slopes. All get the attention better for children. I take that back. Fresh noise has better correspondence to pure tones than narrowband noise. Fresh noise I have not used myself personally. It's a proprietary type of noise, not available in all systems, so narrowband noise is more widely available. These stimuli should be used in the sound field: narrowband noise, warble tones, fresh noise, due to standing waves. Techniques for testing infants and toddlers. You have conditioned play audiometry for ages 2 to 4 years. Reliability for air conduction and bone conduction can be similar to adults. Be positive, reinforce, gamify. Children are receptive to structured play at this age. An experienced audiologist needs to keep the child engaged and happy, putting rings on a pole, putting blocks in a bucket, flying planes into a hangar, keeping the child active, keeping them engaged to demonstrate a time-locked response with a super-threshold task. Help the child at first, but they need to do it on their own. Don't let the task, don't let them do the task when the tone is not presented. In some cases, use a up 10, down 20 method to quickly bracket. Target one low frequency like 500 Hz and one frequency like 2000 Hz per ear. Sometimes an appointment will take 2 visits for pediatrics. Lastly, we have visual reinforcement audiometry, ideally for 6 months to 2 years old. Use animated light-up toys to reinforce head turns or responses. Also use narrowband noise or warble tones when presenting in the sound field. Visual reinforcers, either with toy animals that dance around or video clips on a computer monitor or tablet, can be helpful. Visual reinforcers are placed at 45 degrees to 90 degrees. Unilateral head turns in one direction is all that is required for a response, regardless of the ear being presented to. For children older than 12 months, it's possible to test for localization, but that's kind of a different test. Remember, unilateral hearing loss like otitis media with effusion could affect this, so don't stress about it. Always best to try with earphones when possible. Bone conduction testing is appropriate with the pediatric headband and when time allows, especially if you have an assistant. The assistant's task is to keep the child's attention centered and forward so that they're not looking at the toy reinforcer. They might use bubbles to help center the task, center the child on them until the sound goes off, and then they're conditioned. The sound goes off, they turn the head toward the reinforcer, and then the stimulus head turn signal to the tester that you've got a valid response. Use the same frequency and test modifications that you use in conditioned play audiometry. Those can also be used in visual reinforcement audiometry. That's all I've got for this lecture here.